Good day, welcome back. This is one more NEET recall. It's about a foreign body in the aerodigestive system. How do you differentiate the location, whether it is in the airway or in the digestive system on imaging? Because that is what you need to know in the NEET exam. And is there a deeper clinical perspective, or it just stops with identifying correctly on a 2D image? Now, my idea is to give you the clues about where to find exactly it could be, but also take you into the real life scenarios. So the collections are from my personal collection. The ones which I have taken from the net, I will give credit, plus 2 or 3 which have come from my interventional pulmonology colleagues. I have also given them due credit. So now this is the image that was given to you all and asked to say, I don't know exactly what was the options or the stem. So you know that there is a foreign body in the aerodigestive system. Now, how exactly do I know from this view whether it is in the trachea or the esophagus? There are only 2 hollow passages there, whether it is in the trachea or the esophagus. Now both of them will be lying like this only on an AP or a PA view. There's no doubt. Is there some method of finding out where exactly they are? There is something known as a halo sign which can differentiate between trachea and esophagus. Now what I want to tell you is, when a child comes with a foreign body in the aerodigestive system, that is what the parents maximum will tell. They cannot tell you whether it's in the trachea or the esophagus. That is our job to find out. Now the first clue, if it is in the airway, such a big foreign body, child will be restless. Child can have noisy breathing. Child may be obtunded, or child may be even in an arrest. But if the same foreign body is in the esophagus, child is not going to be that terribly sick. Maximum it will have drooling of saliva. So a clinical clue will be able to tell you where the foreign body would have lodged, even if before you send the patient for an X-ray. So you see, this is one of our patients had to be sent for an X-ray. And I want to tell you one more thing. In an emergency, and a child, even if it is in the esophagus, is going to be uncomfortable. This big coin in the aerodigestive system, even if it is in the esophagus, is going to compromise the tracheal lumen. Patient is going to be restless. You cannot take a proper X-ray. You see, the X-ray has got even cut off. Now you cannot go on repeating the X-ray to find the ideal X-ray. You need to act. So you need to accept this X-ray. You asked for a lateral view and you can find out. You see, this is the airway in the front. The black shadow is the airway. Let me mark it for you. This is behind the airway. So this is in the esophagus. It's about C6, so it's got caught at the cricopharyngeus muscle. That is your first constriction of the esophagus. So the lateral view, you know it's esophagus. More than that, clinically itself, we knew it should be in the esophagus. Why? The child was not that much in distress. Yes, it was in distress not to cooperate for an X-ray, but it was not an impending respiratory catastrophe. That itself should give you a clue. No, this is probably in the esophagus. Now, let's see the aerodynamics of the foreign body. Very small foreign body will just drop in whatever direction, in the airway or in the digestive system. This is your trachea, this is your esophagus. Very small, less than the lumens. They will just drop it without, conforming to physics. But if they are large, both of them will travel like this only. See, at some point of time, they might change their vector. So this, when it drops, it will drop like that. But after a few millimeters or centimeters down the trachea, it might change its direction and lie down like this. Why, you know? Because this part, the rings are incomplete. The body will accommodate the foreign body nicely by stretching and give enough airway channels. This is the natural body mechanism. But here what happens, it will be falling whatever way, maybe this way also. It will remain in this direction because in the front there are solid structures. You see the tracheal rings, only here there is a gap, otherwise there is a tracheal ring. They will give the resistance. They will not allow this to go this way. They will not allow the foreign body to take this line because there are solid structures here and the spine, and the esophagus is a flat tube unless a bolus is going through it. So the foreign body will remain like this. It will get opposed between both the walls. And I told you, you take a lateral view. You see the esophagus is slit-like. So it will remain there in the coronal section. Here also it will be in the coronal section, but it will try to become a partial sagittal section because it will try to take the soft part of the posterior wall of the trachea. So that is the trachea and esophagus in the X-rays. And you take a lateral view, you'll know exactly where it is. More than that, the clinical picture itself will give you 90% clue. Now, let me tell you something. As I told you, everything in medicine will be a spectrum. So somebody has ingested or aspirated a foreign body, they can have minimal symptom depending on the size of the foreign body. Or they can present with respiratory compromise or frank respiratory failure. They can come even in a cardiac arrest. So tracheobronchial foreign bodies are most commonly caused by aspiration. We know it. So the epidemiology of tracheobronchial foreign bodies is bimodal. So suspect in the younger and in the very old. In this area, the incidence is very small, but you'll have an antecedent big clue, like some procedure has been done, a dental procedure, or anesthesia had been given, something like that, or an RTA. Here you'll have a big clue. And the incidence also is very low. But here the incidence is high and you may not get clues. In children, yes, you will not get clues. Similarly, in adults with neurological problems. See how not only the incidence, but you will also know that these will not be giving me clinical clues. The incidence here is low, but I will get clinical history or clinical clues. So what happens? Most of it will be missed at this stage. Somebody coming with frank respiratory issues, stridor or tachypnea or even no breathing or cardiac arrest, you will pick up. But the problem is at this stage it will get seriously missed. Now suppose patient has come to you to the hospital in this stage, you missed it and he landed up here, it is very unfair. Or you missed it and he landed up here, it is very unfair. He was at this stage in his house, they came rushing to you with this stage, that is different. But we should have no business to miss this stage when he is with us in the hospital. So how do you not miss this? By having a high degree of suspicion. Where you will apply the high degree of suspicion? Child not responding to treatment as expected. They might just bring a child saying wheezing. You give nebulizer. You expect some amount of response in a reasonable time, not responding. I'm talking about this stage, not these two stages. This you will pick up. So choking or coughing is present in up to 95% provided he has been supervised. If parent himself doesn't know, there is no clue. Stridor is commonly present. Stridor will be here, you will pick it up. Patients may present with respiratory distress, no problem. They may present just with pneumonia and you'll be treating the pneumonia. Without knowing the inciting factor is a foreign body, it has got lodged in a bronchus and caused a collapse in pneumonia. Or it can be plain wheezing, they'll be sitting in this stage. So what do? A CT is the best for finding out where exactly it is, where in which part of the bronchus it is, whether it is in the upper bronchus, whether it is in the segmental bronchus, whether there is hyperinflation of the lung. Sometimes the foreign body could have even caused a pneumothorax. You must know the holistic picture before you decide to give the holistic treatment. Now, bronchoscopy may be necessary in retrieving the foreign body. Not only that, in a diagnosis itself, because if it's a radiolucent foreign body, you are not going to pick it up on an X-ray or a CT. So in the emergency department, when the patient comes, initial supportive therapy like generic oxygen, oximetry, and intravenous line. Oximetry, you want to know whether they are deteriorating in front of you so that you will take the next possible action. Intravenous line, yes, you need it for you to go into these actions. See? So you keep an intravenous line. Now I know these are all generic. Start O2 therapy, start intravenous, but you must know the objective in that particular scenario. The objective here is to pick up deterioration. The objective here is to have an IV line. So that deterioration, and you want to escalate treatment. For that, you need some IV line to give your sedation. Now, you give all this, you find patient is in stridor. Find out whether stable or unstable. If stable, start your epinephrine. Don't wait, start your epinephrine. Unstable, you have to intubate. After intubating, see where you're going. You're going to bronchoscopy and extraction. No stridor, you can move in for a CT and decide on a bronchoscopy and extraction. Here also intubate, and intubated patient you can take for evaluation and then bring for bronchoscopy. Now look, if patient has come in cardiac arrest, don't waste time talking, initiate your CPR. Intubation is part of your CPR. Not able to intubate, the foreign body itself may be obstructing your tube. Then you need to decide to do a surgical airway. And surgical airway in an emergency is a cricothyroidectomy, not a tracheostomy or a tracheotomy. It is a cricothyroidectomy. So this is from one of my LinkedIn colleagues. You can see the foreign body here. You can see the foreign body there. And a bronchoscopy has been done. See how it's lying down? Exactly what I explained in the line diagram. This is how the foreign body will be lying down. It has been, see, the grasper is approached and it is removed under vision. Now one more, this is our patient, but he did not have this problem. I just want to emphasize the tracheostomy. Fine. You can see he has a tracheostomy here for some other reason. Now tracheostomy patients have a particular problem. They are discharged home. They will not have the strict supervision that a hospital can give. Now when they are sleeping, you can have foreign bodies aspirated. And these foreign bodies are not what he ingests or aspirate. These foreign bodies can be crawling insects. They can get into the trachea. Number one, he will not choke. Why, you know? Because you have bypassed the most sensitive part of the airway and made an opening in his airway. So crawling insects can easily get in without eliciting a big choking reflex from the patient. But they are going to have severe respiratory issues. They are going to have cough. They are going to have pneumonia, unresolved pneumonia. So these are the patients who need an early bronchoscopy. You can pass the bronchoscope through the trachea itself. Of course, you need sedation or anesthesia. This is case-based. And you find a cockroach here. This is from Dr. Tinku. He's from Amrita Hospitals, my LinkedIn Connect. So this is what I wanted to tell. Now, when we send back patients with tracheostomy, whatever reason, we can't keep them till we close the tracheostomy. You send them home for home care. The family or the community takes care of it. Always warn them that when to keep a gauze on the top, so that bigger insects will not be able to get in. Even the gauze is not going to allow even smaller flies there. So always, one, you will tell them keep a gauze, one, to humidify the air, and number 2, to prevent these insects crawling in. Sometimes we even show these things to the patients who are going to be discharged. We show them to the relatives, because relatives, when they see these pictures, they sort of feel empowered. They feel they are no more ignorant, and their care to those patients who terribly need their support will be very much enhanced. So we, on our laptop, we show these patients when they go home that these things can happen to them. So thank you for listening to this. Instead of just telling you this is what you will find in an ingested foreign body, this is what you will find in an inhaled body, inhaled foreign body, these are the constrictions in the esophagus where it will get stuck. We need to move behind that into the clinical part of it. There is no point just telling, putting a 2D image and going on explaining. So I felt I am duty bound to bring the clinical aspect of it. So whenever I look at a NEET recall question, the first thing that ticks me is how best can I bring in some of my clinical scenarios of which we have found in our patients, and which are very, very practically important. They are very simple concepts, but they are very practically important. So thank you again, and please do share and subscribe to my channel. I am getting a lot of views, but it's not translating into subscriptions. Please do subscribe and also nudge your friends to do the same. Thank you.